Have a lingering rash? Can't seem to shake that cough? Oozing ear issues? What about those lymph nodes? The doctors are in the house to help you understand the medical jargon and demystify Dr. Google. This is DocTalk, part of Nightline. Only on Dubai Eye, 103.8.
Dr. Shereen is here, Dr. Sean is here, I'm James Piecowye, and welcome back to the studio, both of you.
Good evening.
That means we have a whole night ahead of us where we get the opportunity to sort of dig into the medical bag and look at a little bit of what's going on in the wild world of medicine, as well as try and unpack what's going on just in our lives. Because you just never know.
Yep. That's right. Yeah. I still have my old black Gladstone bag, the old-fashioned medical bag.
Do they give you one of those when you graduate? You have to go and buy your own.
You have to buy one.
No, I bought you that actually.
You did, yeah. Exactly. Yeah.
I think they're cool.
We don't do a lot of home visits anymore because times have changed, and it's actually always better to see people in the clinic.
In a clinical, a clinical setting of some sort, a clinic or a hospital, or.
I always think of spaghetti westerns where the doctor's coming out with his Gladstone bag and, opens up, gets out the stethoscope, and it's like an endless supply of tools in there,
I still have my medical school stethoscope, actually. I'm very sentimental, You
use it?
Yeah, it works.
Okay.
You just have to change the earpieces, and occasionally you have to change the diaphragm bit, which is the thin layer. Works. No reason why not.
Keep your sentimental old things, it's good. Yeah. We use new things as we have to, and of course most of the things we use these days are disposable. But some of the old things, you keep them clean and you keep them usable, and you trust them, you know them.
It's incredible how many things today are disposable. I mean, pieces and bits that you screw onto stuff or that you're using for exams that in the past would go into the sanitization solution or the light cases, but now it's just get rid of it.
All the earpieces are disposable. Even things like gynecological speculums now, they can be disposable. Some people prefer to. I'm one of the people that still prefers to use the old-fashioned sterilizable ones, simply because I've had a few of them break, which is not pleasant for the patient or the doctor.
No.
So, but they're available. I have used them on occasion. Most
surgical
everything
instruments
is
as well.
Yeah, surgical instruments disposable.
It's a big business,
Suture
right?
kits are disposable.
The number of those tools and things that come in those sanitization packages that you kind of open up like you're opening up a chocolate bar.
Yeah. I tell you one thing that is big business is clinical waste disposal. I wish I'd thought of that as a business. With all the new clinics opening up in Dubai.
I know that everything has to get disposed of as clinical waste, but I've never seen the guys picking it up. And so I always wondered, when do these guys come around?
They come as stealth, stealth mission.
I figure it's the same people who work at Carrefour who reorganize entire rows. When do they do that?
When do they do that?
They must do it,
just when you've learned the supermarket layout, right?
Yeah.
No, the Ministry are very strict on that. Obviously, it is a big deal, clinical waste and how it's disposed of and so on. And so there are very tight regulations. And so in my room, I've got an array of different bins for different things, and we have to kind of, stick to that. What goes in what bin. So there's a sharps bin, a clinical waste bin, a normal waste bin, another bin for just paper, So
at least it's the whole process of recycling, isn't it?
Well, it's very important if you think about it.
Well, you don't want
so much potential for spread of infection, disease. So.
Yeah,
it has to be incinerated, so it has to be collected by the right people and
disposed of correctly.
Completely incinerated,
which is very good. Well, you opened up the door to the office, so why don't we walk through that door, and as we do every week, sort of take a tour around some of the things that are clustering and things that you're seeing. And this, as you always say, there's a lot of repetition here. There's a lot of stuff that happens over and over again. And our goal through this program is to help put people a little bit more at ease, help to give them a few answers to some of the common questions that they might have, so that when they do get to their doctor, they've already got a list of things to start asking without having to consult the internet, which can be, sometimes not as correct
helpful,
as we hope.
Yeah. I mean, we aim to help. So if you have any questions, obviously SMS in or call in.
We take calls on the break, actually. So so don't
on the break.
As soon as you hear us go to the ads, if you want to call, we'll
that's
we'll
the time to call.
Yeah,
but
exactly.
We're not here to sort of treat, diagnose or cure
that would
or
be
whatever.
Unethical.
But,
you can't do that over the airwaves.
No, I mean...
You're good, but...
I don't have my crystal ball with me today, I'm afraid, so... Yeah. I mean, basically, we'll answer your questions, obviously, as best we can, and hopefully give you some useful advice. But yes, it's just today I had a case where a patient wanted something prescribing. This is a patient I've never seen before. I can't do that, even if it's a repeat prescription. If I've never seen that patient, I can't even issue a repeat.
So they came to you to get a prescription for something they already had?
They came to a colleague of mine who I would be the more appropriate doctor to see, wanting a prescription, which is fine. It's something they've been taking for years, but I've never set eyes on this patient, so it would be inappropriate for me to prescribe. Likewise, on air, we're not prescribing if we make suggestions. You do have to see the patient. So most of the story is just sitting and talking to the patient, having a look at them. You can pick up so many things just by looking at the patient, how they've walked in, what they're you can tell if they've got a facial weakness, you can tell if they've got a skin rash, you can tell if they're snuffly, if they're mouth breathing, all kinds of cues we pick up just by looking at the patient.
Which reminds me, I remember the doctor that first taught me that the consultation starts at the waiting room when you call the patient's name and you look at how they get up. It was a neurologist who worked at Atkinson Morley's Hospital, which is now closed down in Wimbledon, when I did neurology. And the patient may hear the name, get up, and come marching into the waiting room looking fine. But when you actually get to examine them, they have quite a lot of weakness, and they're fighting through it because they don't want to admit that they're ill. And all the opposite happens. As soon as they see the doctor, they start limping and and when you examine them, you find nothing really wrong. So you can tell an awful lot by just the demeanour and the way people hold themselves and how ill they are from the start. And when you've seen thousands and thousands of patients, you get very good at it.
Which is why you need to see lots of patients. Childhood illnesses are at the top of the list this week.
They are. It's back. Well, they're springtime illnesses, and it's lovely spring weather outside and almost spring. We're February, so we're just at the end of winter. But March, April, May, when you see a lot of these. But this week I've seen 3 cases of roseola infantum.
And I said, it's back. We haven't had any roseola for months now.
Yep. Probably about a year.
Yeah, about a year.
Yeah, I mean, it can sporadically occur. Now, it can occur in children right up to teenage years as well, but generally it's in the under 2s. It's a viral illness, fever and a sore throat and a rash, and a particular kind of rash that's kind of patchy red. It's slightly different sizes and shapes. Google is actually quite useful for rashes.
Head to the Google images and take a look.
Put roseola rash images. As long as you'll find that 9 out of 10 of the pictures are correct. Some of them are not. Because some of them come from sites where it says this rash, which is not like roseola, so it'll come up with under the same search.
Yeah, you have to be. We always say you have to be careful of the websites you use and make sure they're reliable and so on.
Yeah, but so this week I'm seeing a few cases of roseola.
So what do we? There's nothing we can really do for.
The rash is on the back of the neck, up into the face, down on the trunk, blotchy red rash.
People get very nervous when they start seeing this.
Yeah, it's a virus. It's one of the herpes viruses, of which there are many. People know herpes type 1 as cold sores on their lip, type 2 as the same thing down below. But this is herpes virus number 6 and sometimes number 7, and it's largely harmless. There's not much you can do. Keep the child happy with some paracetamol or ibuprofen or something for the appropriate dose for the child if they need it. But the virus burns itself out quickly. Fever goes, sore throat goes. The rash hangs around for a week or more and then disappears. You're contagious while you've got the fever and the sore throat. But once you're bouncing around and happy and playing, you're okay.
A lot of what we do is manage anxiety as much as anything.
I would imagine.
Yeah, we manage the illness. Obviously, we manage risk. We take decisions based on best evidence, and we have to weigh up risks versus benefits. We have to make sure our decision is sound, that when we say it's roseola, we're not missing something more serious or, whatever it is. We also manage anxiety. And in this case, it's anxiety in the parents. Nobody wants to see their sort of splotchy child. They get very worried.
Is this going to be forever? How long is this going to last? Is this going to leave a mark?
Is it going to get are my other 3 children going to get the same thing?
Yeah.
And all their friends and me? Yes. Or particularly if the mother is pregnant again, she's maybe worried about about what the risk is there.
And if a mother is pregnant again, is there a risk?
Well, it's not really, essentially. I mean, it's not quite the same as, because, you with roseola, you generally don't get it as an adult.
Right.
So it's kind of similar to having had a cold or a flu while you're pregnant. I mean, there's a very small risk if you get a huge fever for a long time or you're quite ill in yourself, but ultimately there isn't really quite a risk in the same way as if you get chickenpox as a pregnant mother and then you're very early pregnant, it can cross the placenta. But roseola is not one of those that's really seen in adults.
Okay. So it's really about management, and it burns itself out?
Yep.
That simple. The doctors are in the house. This is DocTalk. If you want to get involved in the program, this is how you can do it. The doctors are here. This is DocTalk. If you want to get involved, you now know how to do it. And we're working our way through a list. We do plan this show.
We sometimes get sidetracked, but we have a general plan.
Yeah, we always have a plan. And if we get to it all, great. And if we don't, well, then we just start again next week. But great questions come in, and I love these questions because they're just great. This is a toenail question.
And I like toenails.
Shelton said, "Hey guys, just wondering, since I and quite a few of my friends involved with football have this issue. I lost a toenail during a game twice over 2 months. Now I have something like a nail, but it's black and thicker than a nail, almost like a super thick skin. Do I need to get it removed?"
Well, no, is the short answer. Yeah. Assuming if you lost a toenail because of trauma, if you actually kick something and it rips into your nail, if it pushes it back up and pulls it off, so the nail comes off there and then with trauma, then you've lost the nail, yes, but the cells at the base of the nail are where the nail grows from. So it'll generate from the end nearest you, and slowly grow out a bit like a wave rolling down a beach.
Right.
So it's thicker at the base and will carry on. Now, if it's black, most likely there's a bit of old blood under there, probably from the bruising that was deep in under the nail bed at the start. So as it grows down, you'll have that staining that'll grow out as well. It takes, nails actually, they grow at 0.44 millimeters every 24 hours. So they grow half an inch a month, basically. If they can, they can grow slower if you're ill, or interrupt if you're sick, and if you keep injuring it, of course, then you will you maybe lose it again.
Well, if they're footballers, so they're constantly traumatizing their feet, and we've got runners who've got similar issues. Saw someone walking around with a sign at one of the races saying, "If you don't lose a toe, are you really running?"
Yeah,
a toenail. If you don't lose a toenail, are you really
ballerinas who do point work?
Yeah.
So if you constantly impact by running, bam, 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 then you'll bruise the nail bed, and you often will find that the nail will lift and peel off later because you damaged it during a long run. Whereas if you lose a toenail through actual trauma, if it actually impacts and ruptures or rips at the time, very painful. But they always regenerate.
Now, here's a question. As Shereen is making this grimacy face at the fact of ruptured toenails and stuff like that, folks who've got toenail issues, are they more susceptible to fungal infections?
Yes, I guess once you've damaged the integrity of the nail, anything can get in. And also, if they're athletes and they're by definition they're wearing sort of sweaty gym socks and sports shoes, I guess it would make them more susceptible. Anything that damages the integrity probably could. Yeah, I would have thought so.
Yeah, I mean, for instance, if you have a manicure or pedicure, you're at slight risk of getting an infection with bacteria or fungus. So yes, you're breaking the barrier, aren't you?
Okay, so there we go.
But in this case, if you keep bruising it, particularly if there's no nail on the surface because the nail came off last week, you're going to make it bruised much more easily, and the new nail coming through will look blacker, perhaps.
All right, so
time and in the off season it'll grow back.
Steel toe caps.
Steel toe. Can you imagine?
In football, can you imagine?
Can you imagine? That would not be good.
It's probably illegal.
Yeah. Let's head back to the office. We didn't quite finish up there. Sinusitis, Shereen.
Yeah, I've been seeing a few cases actually of sinusitis, and itis is always an inflammation of something. In this case, of your sinuses, and people talk about sinuses, but they don't really.
A lot of people have sinus issues.
Yeah, a lot of people don't really know what they are. They're basically air spaces, air pockets, and there's one either side of your nose where your cheekbones are, which are your maxillary sinuses, and then you've got frontal sinuses, which are just above your eyebrows. And sometimes people get headaches with that. You can get facial pain. And so basically it's inflammation of those air pockets, those sinuses, and it's the lining, the mucous membrane on the inside that becomes inflamed and can become infected. If it's infected, you can usually tell. You often you'll feel congested. As I say, you can get headaches if it's the frontal sinuses. You may have a runny nose, but you may not. It may all be sort of dripping back in. Bacterial infections classically give you a foul smell or a bad taste. And they can make you sick. They not necessarily, but some people are sick with them. They're feverish and generally not well. But it's more that dull pressure. People will describe sort of dull pressure, always feeling a little bit bunged up, just occasionally having to clear their throat in the morning because they're getting something called a postnasal drip. That often, those are indicators. But classically, if people say, I have a foul smell in my nose, I wake up in the morning.
I was talking about one of those foul smells.
Yeah, you were. So you need to be seen, not off air, professionally. Yeah, but yeah, it's often often an indication that there might be a bacterial infection there.
So if it's an infection, get treatment, or there's a lot of over-the-counter things that people use to sort of help stem the symptoms.
Yeah.
But
I mean, you can use decongestants and things like that, but that often just treats, as you say, treats the symptoms. Occasionally, if it's an allergic type of picture, antihistamines will help, but generally, you can tell if there's a bacterial infection or if it's become a chronic problem. Then you really need to see an ENT specialist.
And we often use second-line antibiotics for sinuses because often the bacteria that's in there has been there a long time, may be resistant or may need something a bit more powerful than your usual antibiotic. So I tend to prescribe both the decongestant at the same time as a second line, the sort of thing you keep in reserve for more difficult infections. Yeah. And you need to treat them for a bit longer. Imagine this is a space full of air where the lining's inflamed and there's a little pool of pus in there. The blood circulation's on the outside. So you need a higher concentration of a better antibiotic for longer to get rid of it.
Into that space, yeah.
Because you're not going to operate to open it. So unlike most, say, abscesses or boils where you might pop it, you can't really do that with your sinuses unless you later end up needing surgery. So we're quite aggressive with the antibiotics when we need to be for sinusitis.
Always good to end up at an ENT. Is that sort of the last resort?
That's what they do for a living, exactly. Yeah. I mean, family medicine can treat most first cases of sinusitis, but if this keeps happening again and again and again, somebody needs to put a camera up your nose and have a look. Or you can organise a CT scan of your sinuses.
Oh, okay. What's it like getting the camera up your nose? Just out of curiosity, did you ever have that done?
Yep. I've had it done. I have a father who's an ear, nose, and throat surgeon.
He just brings home the camera and say, "Hey, let's have a look at your nose."
Just experiment. No, I'm just kidding. I did actually need somebody to have a look at my nose.
And what's that feel like?
It's not pleasant, but it's not. It's
How
not
far
terrible
up does the
because
camera
they
go?
do use a local anaesthetic spray.
Yeah, okay.
It goes all the way around, up the back and round.
It's like a snake going up your nose.
Yep. That doesn't actually show you the sinuses themselves, but it gives you some indication of the state of your your sort of mucosa, the linings, and so on. But the best imaging for sinuses is actually a CT scan to get right inside and look. There's a simple test that can be done in the office, which is basically get somebody to put their mouth around a disposable pen torch and close their lips, and then you turn off the lights and you can see whether the light comes through the air spaces in your cheeks and your frontal sinuses or not.
Okay.
It's one of those really simple tests that, if you were in a place with limited resources that you could do and say, this is probably sinusitis.
I'm just thinking of that camera up the nose. Does not sound fun. And your face is saying everything.
Yeah. But the new cameras are thin now.
They're very, very thin cameras. You do have local anaesthetic put up there. I think it's more the thought of it. Often.
I think so, yeah.
And you can look at where, what's draining out of the sinuses. The little holes are called ostia.
Oh, interesting.
Yeah, that's true. You can, although you can't look into the sinuses, you can look at the general condition of things. Just brings me on to a completely irrelevant story from medical school, where I was the only girl in our physiology group, our tutorial group, and I used to get picked on for all the experiments. And this was back in a time before they'd really regulated what medical students did to each other. It makes me sound ancient, but it's sort of 1992, 93 probably when I was doing these experiments. I started medical school in 91, so that'll be about right. And I was picked on for I can't even remember the purpose of the experiment because what they did was they put a nasogastric tube, which goes from your nose to your stomach as the name suggests, down, up my nose, into my stomach, and then gave me insulin for some unknown reason. To this day, I'm not sure how the two things are linked, because I was completely zonked out. I was just wandering around in a daze.
Interesting.
I just dropped my blood sugar through the floor and stuck a sort of
Just have
tube
to measure
in
it.
my...
You see, we used to have to be our own guinea pigs for the physiology trick.
That's why I
training.
pull a face now every time we discuss something. It wasn't so much the camera that my dad used to actually clinically look at something. It was that putting things in my nose always has a bad memory, because, of course, I didn't have local anaesthetic or anything for that.
Now it's regulated, though. Far more regulation.
Oh, yeah, no, they don't do those things at medical school anymore. I think we were probably the last year to do that experiment.
I had to drink 2 litres of salt water to check my kidney function.
2 liters?
Yeah, it was awful.
Salt water makes you really sick.
Yes.
I mean, you take just a thimbleful out of the Gulf, and you're almost hurling 2 liters.
2 litres of physiological saline. I was allowed to put a little orange juice just to make it nicer flavour, and then they checked the sodium coming out in my urine. Yeah, I got
Something
that
wrong
one.
with that.
That wasn't bad.
They don't do those things anymore. Medical students are pampered now.
Yeah. We even did, we did real autopsies at the time, and now, of course, it's all done on computer.
Yeah, we had real bodies.
Okay.
I had a real skull I had to carry around with me to kind of learn the bits of the skull. I actually managed to get it out of customs at Heathrow, into customs at Dubai, out of Dubai again, back to Heathrow.
Being checked all the time.
One Easter break.
Madam, do you know you have a skull in your luggage?
You have a skull in your hand luggage. Yes, I'm a medical student. You have a skull? Yes. Actually, at the time, the lady that still works for my mum, as a house helper, she absolutely freaked out. She saw this skull on my desk, and she just screamed. All I could hear from upstairs, was screaming. And medical school.
Dr. Shereen is here. Dr. Sean is here. This is DocTalk. This is DocTalk with Dr. Shereen Abib, Dr. Sean Petherbridge, and we've been talking about runny noses and stuff, and those is always the thing in the morning.
Side effects on radio. Sound effects.
And we got a text in that says, I always get up in the morning with a runny nose, or sometime in the morning it just sort of dissipates and goes away. Any idea what that could be?
Well, we have to ask our favourite question. What colour is the mucus?
Oh, I know, that's a good one. Is it green? Is it
green?
clear?
Is it clear? Yeah.
Yellow?
Does it smell? Yeah. I mean, if it's just a
texture.
clear
Get your fingers in there.
Is it thin or is it
gooey,
chunky?
sticky?
Chunky,
yeah. It's your homework, everyone, for tomorrow. Please SMS through or send us the email and images, Nightline at Dubai1038.ae.
No, but usually
make a
if
collage.
It's just Instagram mucus photos. Yeah. Usually if it's just a clear runny nose. I mean, we call it a runny nose is basically a rhinitis, itis, inflammation of your nose. Just it gets runny. If it's that sort of clear runny thing and it's there in the morning, clears up during the day, generally it's allergic. Generally.
Yeah, I'd agree. Mostly a vasomotor rhinitis. So it's as you're exposed to something So if it's
dust,
say it's traffic
hair.
Fumes or dust or something, you get out into the environment and then it starts. Then you get to your office. It's still going on a bit for the exposure, and then it'll calm down a bit when you've been in a different enclosed environment. And so it's probably a community-related, environment-related allergy.
Is it possible that if we start getting some color involved, then you've got a cold or something else kicking in? And
yeah, I mean, usually if you've got, basically the color comes from you're fighting an infection, so either viral or bacterial, and you've got white cells in there, and they're killing the viruses or killing the bacteria, and that's what creates pus or greenish, yellowish, thick mucus. So if you've got an abscess or a boil, obviously then it's pus, and if it's your nose, then it's the sort of greeny or yellowy mucus. It's because of the dead white cells with the dead bacteria inside.
In the case of this person, I think it's, as you said at the beginning, it's clear, there's no smell, it's just a runny nose that disappears.
It's I mean, again, as we said, we're not diagnosing or treating on air, but it does sound allergic, and it may be that he could try a sort of nasal decongestant last thing at night or first thing in the morning, depending when it's worse. If he's waking up with it, sometimes using a decongestant just before you go to sleep. You can buy them over the counter, just a simple one. If that's not helping, Again,
perhaps.
antihistamines might help, but it's probably wise just to pop in and see your doctor and make sure that nothing's being missed there.
Yeah, that sounds like a good plan. Another real quick one. I wanted to jump over into the world of burns, only because I've heard a lot of people talking about burns. I guess they're burning themselves, whether it's on the stove or ovens or barbecues.
Quad bikes at the moment
Quad
as well.
bikes, yeah, lots of folks out there and hit the mufflers and stuff like that. And there's varying degrees of burns, but I am always amazed at some of the crazy treatments people have. When you get a burn, throw toothpaste on it.
Oh, no.
Put some lard on it. I've heard that one.
Well, following on from the quad bikes, I mean, Shereen and I both run the medical side of the big motorsport events here, and I was in the World Conference for Motor Racing Doctors last December, and one of the topics was burns, because we had two of the world's leading burns guys there. And well, you can classify burns very easily. If it's superficial, it hurts because you haven't burnt the nerve endings. If it's not blistered, it's just red. That's first degree. Second degree, it's blistered, it hurts, but it's deeper. Third degree burns burn right through the skin. Part of it doesn't hurt. It's white and flaky and leathery, and obviously that's a serious burn that needs serious treatment and even grafting.
That's what they call third-degree burns.
Okay.
Yeah.
A third-degree burn. Well, and then the fourth degree is actually when you've been burnt properly by fire, and it burns through to your bone and burns all of your tissue, and that's obviously that requires serious treatment by plastic surgeons.
So first and second degree are kind of
what most people see. Yeah. What do burns surgeons want? What do burns doctors want? They don't want you to mess with the burn. You need to cool it down, but not with ice. The reason being that tissue is damaged. The blood vessels are damaged. If you then shut them down with ice, you then cut the blood supply to even more of the tissue and extend the damage. So it needs cool or lukewarm water, room temperature water in copious amounts.
See, I always thought it was you wanted to have cold water.
Not ice, no. Yeah. So, and you remove anything that might retain heat, like your rings or bracelets. And if you can, you take the clothing off unless it's stuck to the wound. And you need to cover the wound. The reason it hurts is the air going past it, because it's raw tissue. Okay. So if you cover the wound with cling film, plastic wrap.
Cling film, best thing. Yeah, we keep it in the medical centre for the Desert Challenge, and they put it in their medical bags.
Yeah,
keeps it clean, keeps it dry, keeps moisture in.
If you haven't got that, you can use cotton that doesn't have any debris, like a tea towel, but it has to be wet and soaked. But the best thing is just to cover it with plastic cling film. Yes, exactly.
And then when you get to your hospital, the cling film comes off easy.
Yep.
It doesn't stick.
It just comes off.
But what you don't do is you don't put any ointments on it at all. No
ointments.
Vaseline.
No.
Yeah. No creams. Certainly no toothpaste or weird and wonderful things, because all of that has to be taken off again for you to dress the dressing, and that will be either painful or will interfere with your wound healing if you need grafting.
So putting gauze on is definitely not a good thing, because it's all going to stick.
So lots of water.
Unless it's soaking wet gauze.
Yeah. So the treatment is water, not ice, and cover it ideally with cling film, and go to the hospital and get them to see you and treat you. And the person to see a burn is the ER doctor if it's minor, or a plastic surgeon if it's major.
Okay. So.
And I mean, the reason we worry about burns is the infection risk. Again, you've damaged the skin, you've breached that barrier. It's very easy for them to get infected. With babies, burns are a whole different issue, because babies have a smaller surface area. So a burn that in an adult would be not necessarily a huge deal, even if it's just a scald to you. Let's say your whole forearm is scalded as an adult. It's not such a large percentage of your body surface area. But as a baby, if you scald their whole forearm, or let's say the classic one in a bath that's too hot, both their legs, that's a very large surface. That's a very large percentage of their surface area. And of course, burns lose moisture because you've damaged that skin layer. It will lose moisture, and babies can become, and obviously you're opening it to infection. Babies can become quite sick from a relatively small burn. So the exception to the rule of saying, don't worry about a scald or a superficial burn if you're an adult, babies definitely, you really, whatever the burn, you probably need them to be seen.
Okay. So which is always why check the bath water. Don't make sure it's not too hot. Check the bath
water. Don't keep your tea within easy reach. I mean, we've seen babies scalded by hot tea.
You're running around in the kitchen and you drop something off the stove, which can easily happen as you get distracted.
I've seen people with children, and I'm surprised that they're cooking on the front 2 rings of the stove.
Yeah.
You know, always cook on the back rings when you have toddlers, because they'll grab things.
One of my boys, when they were just tiny, maybe 18 months, we pulled some cookies out of the oven, and the old wrist went up right on the corner of the cookie sheet. Till this day, there is a mark on that wrist that can be seen.
It's very easy to do. Yes, exactly.
And boy, I caught it from my wife when she got home. Like,
it was on your watch.
Yeah, it was my watch.
On your watch. Oh dear.
It was my watch.
Yeah. It's easy. I mean, it's so easy with toddlers, especially small babies, less so because they're not mobile. But with small babies, obviously, you have to be careful of the temperature of the milk or the food you're giving them, the temperature of the bath. You're responsible for that. But with toddlers, anything you put down that's hot, and we've seen some nasty scalds and even
I guess scalds on hands and things
too.
So
even second-degree burns from tea, for example, where the milk has been heated as well. So it's really scalding hot tea, and they'll just pull it down and nasty burn. So please be careful.
The doctors are in the house. This is DocTalk. If you want to get involved, this is how. Dr. Shereen and Dr. Sean are here, and we've got more texts coming in. So let's jump back to the SMS machine. By all means, keep your SMSs coming through. First one is from Ahmed, and he says, "Hello, docs. What do you think I should use to get rid of blackheads of a not so small size that suffers from shaving?"
I imagine it catches them on skin
shaving.
lesion or something. Well, I mean, the blackheads really are just blocked pores with grease in them. So if this is something that sticks up a bit, there might be a bit of a cyst behind it, or maybe an ingrown hair or something like that. If it's not so small, then it may be more than just your regular blackhead. A plugged pore of some kind that's quite big. If he catches it shaving, it'll probably be a little sebaceous cyst. So this is the sort of thing that might need removing by a dermatologist, might need either evacuating or a little bit of minor surgery. Obviously over the internet, over the phone, over the radio. We can't, you can't diagnose, you can't see. We don't have any pictures, and we haven't seen the patient. So,
but it sounds like something he probably needs at this. If he's catching them shaving,
then it's causing a problem. So it needs fixing. I mean, he could go along to his general practitioner at first. Can have a look, diagnose it probably fairly easily because. Lumps and bumps and things are surgery 101. It's pretty easy to diagnose. It then probably will need some definitive treatment to get rid of it. But fixable, absolutely, yes.
And dermatologists have some of those neat tools for blackheads. It's kind of,
if it is a true blackhead, yes. I mean, they do have tools, but it may be more than that by the sound of it.
If it's from shaving, could it be an ingrown hair? That's the other thing.
I probably could. They can look black because, of course, the hairs
little black hair under the skin, maybe. Sounds like it needs looking at.
Yeah, sounds like it for sure. So now he's got his advice. He needs to go in and have a conversation. We've got an acne question as well.
Right. Yeah.
Acne rosacea.
Yeah.
It's an adult form of acne, and it's different to teenage acne in some ways in that it seems to limit itself to the center of the face, so just the lower half of the nose, the cheeks, occasionally the middle of the forehead and the chin. She says touching her face. And it can be, it's usually red, involves some little broken blood vessels as well as the sort of cystic areas of the acne.
Recently exactly with what you're describing.
Yeah. It's common in women. It's much more common in fair-skinned people, and in women often it's cyclical, related to the menstrual periods, and you need to see a dermatologist. There are treatments available. Usually with adult acne, it's more difficult to get rid of permanently than teenage acne. Really? It tends to be treatable, and then they kind of get it again some months down the line. Oral treatment like antibiotics and things like that can help, but actually things like Roaccutane are better, which is a vitamin A derivative. For that you need a specialist consultation and a specialist prescription because you need blood tests for it. And in the case of women on Roaccutane, they absolutely must not get pregnant because it's very damaging for the fetus. And also now there are new laser treatments that are available.
I'm always worried about those. I mean, I hear people talking about them, but I don't know.
No, they seem to work, and really? they have good results. Yeah, it's kind of a superficial laser, and they can also use blue light or pulsed light and things like that, and it just heats up the bacteria inside the inside those little cysts till they die, basically. But it doesn't have any long-lasting damaging effects so far in any of the studies.
People who had bad acne when they were young, do they tend to suffer again when they're adults? Or is there any correlation that you've ever read? Or
No.
Sean's shaking his head.
No, it seems to be. I mean,
it's just unlucky if you have acne rosacea. When you're a teenager, acne that you get there is acne vulgaris. Acne rosacea is related, but it's a different thing.
Okay. Yeah. Well, I hope that helps. So basically, you need to go in and have a chat with your GP, but ultimately you need to head over to the dermatologist.
Well, the SMS says, any advice? Yes. I mean, there are treatments, and yes, dermatologists are increasingly better at treating it because there are newer treatments.
I wanted to jump back because I heard some folks talking over the last couple of days about blood pressure and questions coming out. What's your blood pressure? And I don't know. It's going around the office. People are asking.
I like it when patients come in and they say, I have blood pressure. And I'm like, I'm glad, otherwise you'd be dead.
Yes.
We all have blood pressure, but what they mean is high blood pressure.
Yeah, and what is high blood pressure? What's normal? Well, textbook normal, we use millimeters of mercury as a measurement. 120/70, say, is perfect for your average sort of fit 21-year-old. The top number is the systolic. It's the pressure in the vessels when your heart squeezes and pumps. And then it spends 1/3 of its time doing that, 2/3 of its time relaxing, and that's the lower number, the diastolic number. And so that one's the more important one, really, if you're looking at the overall pressure. When you exercise, your heart pumps, you feel it pounding in your chest, and up goes the top number. The bottom number does go up, but not very much. So there's a bigger difference between the two, and that's your pulse pressure. You feel your heart pulsing, and it should do that when you exercise or when you're stressed or adrenaline is flowing when you're arguing. That's not really high blood pressure. It's a normal physiological reaction. Okay. But if both numbers go up...
Pain puts your blood pressure up.
Exactly, it does. Yeah. And
children.
Yes.
Just thinking about them.
So teenagers.
I've got 2 now, 2 out of 3 teenagers.
I got 1 leaving to university. I think I've got high blood pressure now. Just the thoughts.
The thought. Yeah. Your bank account. You're thinking about your bank account.
I'm just thinking I was in university once.
Oh yeah, that too. Yeah. That too. I was thinking of more practical things.
Yeah, I'm thinking of that as well. Dad, need cash.
Now.
So that raises the top number as your heartbeat pounds in your chest. The big difference between the two is what you feel as a pounding heart. But if both numbers go up, particularly that bottom number, then your resting pressure in the system goes up. That's hypertension, high blood pressure. And you may well get no symptoms at all, but some people get headaches or feel a pressure type pattern. To diagnose high blood pressure, you have to have 3 readings over 3 consecutive times when it's consistently above normal. What is the top of normal? Cardiologists generally say 140/85. We'll let you get away with 145/90 maybe. For aviation, for instance, for an occupation, FAA rules for America, above 150/90 and you're grounded. You're not flying as a pilot.
Okay.
So, you can really, there's a little bit of leeway. But let's say, 140/90, your blood pressure's at the top of normal. There's a reason for it. You should be a bit fitter, maybe. But if it's right up 160/100 and consistently like that, then you have an issue. It doesn't necessarily mean medicine. A lot of the time, you just need to exercise and get fitter.
And there are obviously risk factors as well, so you can be genetically predisposed to having high blood pressure. In other words, all your family members have had high blood pressure, and it's the way that your blood vessels operate. Smoking clearly,
or the way they age, actually.
Because I mean, yes, just how they are. The smoking, obviously, because what smoking does, it makes the lining in your blood vessels more rigid, and so therefore you're not able to accommodate. So if you imagine blood vessels are like pipes, so if they're narrow and rigid, then you can create a high pressure system. Being overweight, because you're putting strain on your heart, that can be a contributing factor. As Sean said, I mean, there are lifestyle factors that can be amended. Genetic factors not so much, but lifestyle factors certainly can be amended. In women, often the contraceptive pill can put their blood pressure up, and it's one of the things that should be done, which is why I object so strongly to the pill being sold over the counter, is one of the things that should be done. Every consultation for a repeat prescription of the pill, a woman's blood pressure should be checked.
Okay.
Yeah. So blood pressure is important. It's It's not so much the short-term problems, it's the long-term problems. If your blood pressure's up for a few weeks, few months, even a few years, you probably won't notice. But after a while, your heart's been working so hard for so long, then you will have a problem.
So the heart has to work obviously like a pump against this back pressure in the vessels, in the pipes. And you can damage the heart. You can also damage the inside of the pipes themselves because of shear forces. Any engineers out there will tell you the higher the pressure system in a pipe, the more shear forces there are, the more likely you are to damage the internal lining of your blood vessels, especially, as I say, if you've got these other risk factors like smoking and so on. And then you can damage the end organs. So, like, for example, the taps, the kidneys can be damaged. You can damage the brain because the brain is very sensitive to the pressure there, so you can trigger strokes and things like that. So it really is, as Sean says, it's not only the immediate effects. People think, oh, well, if I don't have headaches, then what's the problem, or if I'm not suffering with it, what's the problem? But it's the hidden damage that can be done just by running a constantly high pressure system.
And if the blood vessel lining is damaged, then the sticky cholesterol sticks. And if that sticks, that narrows the lumen and the pressure goes up even more.
So you got
So it's
cholesterol
all
and
If
related.
that happens in your heart, you can have, the
Bingo.
blood vessels in
Yeah.
your heart get narrow and they have these little sticky plaques and they're because of the damage.
Yeah.
There you are. It's a heart attack waiting to happen.
There we go. Which is why I guess every time we go to the doctor's office, they want to take your blood pressure.
Yeah, and it's also why we tell people to lose weight and get fit.
Yeah, and stop smoking.
There we
Yes.
go. Eat better.
Indeed.
Yeah, and stop smoking.
And stop smoking.
And I'm going to keep saying
Stop
that.
smoking.
Nobody should smoke. I mean, it's 2015, really. I mean, that was last century's thing, really.
Yeah.
We all should give up smoking, people. Come on, you can do it.
I'm so impressed when you still go to the stores, though, how many different brands of cigarettes they have, because I'm wondering who's buying them. Although I do see people smoking. I'm always shocked when
I'm a vigilante though. I've seen when I see teenagers buying
Oh,
cigarettes, I get really cross. I was queue jumped though at
By
a
a
supermarket by a teenage
who need to smoke.
girl who needed to buy her cigarettes, and I got very cross, I have to say.
Did you get it on video?
Much to the embarrassment. No, much to the embarrassment of my teenage daughter.
She didn't get it on video either?
No.
Oh, okay.
No, she just probably tweeted how embarrassing her mother was.
My mother is so embarrassing.
Well, we're out of time. I really
Right.
appreciate you both coming in. Dr. Shereen Habib can be found at the Well Woman Clinic on 2nd of December Street. Dr. Sean Petherbridge at the Keith Nichol Medical Center on Jumeirah Beach Road. Shereen, hit us with your tag.
Be happy, be well, stop smoking.
Exactly.